Thank you for being here and for sharing your insights in this seminar. I have the pleasure of chairing the first panel of today with two fascinating presentations on some quite different but very pervasive technologies, which many of you probably have in your pocket or maybe around your wrist. We have a presentation on COVID tracker apps by Michel Walrave. And we have a presentation on health apps and self-trackers by Katleen Gabriels. Two different technologies, but which poses quite a substantial, essential questions also on trust. Trust in experts, trust in professionals and learned experience in the case of the health apps, and trust in government for the COVID tracking apps. We're going to do the two presentations behind each other, and after that there's some time hopefully for questions. If you have your question ready and you're ready to already put it in the chat, you can do so you don't forget about your question when the presentations are done. After the session we can then pick up on the different questions. So let's start with the first presentation by Michel Walrave. Michel is Professor of Communication Studies in our Faculty of Social Sciences, and chair of the research group MEOS. He does research on online disclosure of information, as well as privacy issues which are related to that, the motives, but also the risks of these technologies. For instance, you had a big research on cyberbullying and hate speech, Michel. So that's a bit the context of your research. I think you can add to that in your own presentation if I'm not complete or not correct. Recently, you did some research on contact tracing apps, and that's the basis of your presentation today. And we are really looking forward to what you have for us in the coming 20 minutes. I'm also going to have a look at the time so that we stick to the 20 minutes and we have some time left for presentations. Michel, the floor is yours. Thanks.
Thank you very much, Wouter, for your introduction. Hi, everyone. Welcome to this presentation, and thank you for attending this GOVTRUST conference. If everything is okay, you can see my presentation now?
Yeah.
Okay, thank you very much, Sophie. So, as Wouter rightly said, most of us have observed and even personally experienced in the recent years during the COVID-19 crisis, the apps that have been developed for COVID-19 related contact tracing. The COVID-19 contact tracing apps offer users the possibility to keep track of their proximity with other app users. They receive a warning if they were close to other users who tested positive for COVID-19, and if those users engaged in the procedure to anonymously warn other CTA users, other contact tracing app users they crossed paths with. Traditionally, contact tracing occurs through contact center operators, where the operators interview individuals who have been diagnosed and the people who have been in contact with them. This form of contact tracing that is also used in other pandemics can consume significant amounts of time and human resources. Moreover, it can be difficult for the interviewees to recall strangers they met, for instance, in public transport, and who fit the conditions for close range proximity. Therefore, contact tracing through smartphones has been rapidly developed and implemented in several countries. And although my title of this presentation could sound something negative, I would like to start with some good news. Well, the good news is that in a record time, several contact tracing apps have been developed thanks to the huge collaboration of major scientific labs and companies. You see, for example, in this graph of the Council of Europe, that sometimes a number of apps have been developed in several countries. Some apps concentrated on contact tracing, while others included also supplementary information like self-diagnostic tools, and also in some countries, the apps were used for quarantine enforcement. In Belgium, the CTA Corona Alert was launched in September 2020. The app was developed based on the DP3T, distributed privacy preserving proximity tracing architecture, and this was combined with the exposure notification interface provided by Google and Apple. The app was downloaded by 1/3 of smartphone users in Belgium. So the Corona Alert app in Belgium only serves to detect close contacts of COVID-19 infected persons. It does not track location and does not link information with personal data. Also, supplementary statistics and other topical information is included in the app. Moreover, as the DP3T protocol has been used to develop Corona Alert, and also other CTAs in other countries, cross-border interoperability was made possible. That's the good news, but what is the bad news? Well, the effectiveness of the apps that have been developed and widely communicated in several countries, well, the effectiveness highly depends on its public support and use. However, a high discrepancy is observed between uptake levels in several countries. This jeopardizes the cross-border interoperability, which is very important as traveling resumes. Reports have also indicated that users experience a threshold to warn other contacts when their COVID-19 status is confirmed. For example, data from the developers of the Belgian CTA state that 1/3 of users who received a positive COVID-19 test result confirm their status through the app, which automatically and anonymously warns close contacts who use the app. So 2/3 did not. This lack of implementation of this last crucial step also diminishes the effectiveness of the system. Also, shortcomings have been reported concerning the implementation of awareness-raising campaigns to stimulate citizens to use the app, to accompany them in their day-to-day uses, and developing also new functionalities that could augment the usefulness of a contact tracing app. Moreover, several research institutes and civil rights organizations have issued reports on uptake levels, but also voiced concerns about the ethical and legal aspects of digital contact tracing and a possible function creep. Concerns about governments extending data collection and use beyond what was originally envisioned in the context of the pandemic. As contact tracing app uptake is key for its effectiveness, it's important to investigate the factors that stimulate but also slow down its use by the population. Therefore, we conducted quantitative research to investigate the factors that stimulate or slow down app uptake in Belgium. As still a majority needed to be convinced of using the app, we investigated the reason non-users report or why users stopped using Corona Alert. Moreover, as apps need so-called killer applications to make them indispensable by motivating users to install them and continue to use the app, we wanted also to investigate which potential functionalities would get support from users and non-users. Let's start with the first study on the factors influencing CTA uptake intention. This study, and also the second study that I will briefly present to you today, was conducted in collaboration with the University of Ghent colleagues Kato Waterloos and Koen Ponnet from IMEC MICT. We conducted a survey study, and our central model in that survey is the Unified Theory of Acceptance and Use of Technology, the UTAUT model. This theory is used to investigate the factors that influence technology uptake intentions, and it has already been widely used to investigate uptake intentions of several innovations. Let's have a look at the different constructs of the model. You find them summarized also in the model on this slide. First of all, performance expectancy is the extent of the benefits that users expect from using a technology. Applied to our research context, it can be implemented as individuals' expectations concerning the app's performance in detecting positive cases and in also contributing to the prevention of the virus's spread. Effort expectancy is the degree of ease or difficulties expected for using the COVID-19 app. Facilitating conditions are individuals' own resources, but also the external support they can count on to use the technology. Social influence is in the UTAUT model inspired also by other theories like the theory of recent action, theory of planned behavior, so you can compare it with subjective norm. The social influence refers to individuals' beliefs that important others in their lives think they should be using the technology. And Venkatesh, one of the authors of UTAUT, has called for the inclusion of supplementary constructs to further understand consumers' technology uptake motives, but also their thresholds. We therefore included 3 supplementary constructs in the model. First, individuals' level of innovativeness was measured. How individuals are motivated to keep up with the pace of technological innovations and how individuals are also influential in their social network concerning digital innovations. We also included privacy concerns, as several studies on health informatics found a negative association with health-related technology use. Moreover, COVID-19 hits individuals and their entourage differently. People differ in the way they perceive the actual or also the potential impact of the COVID-19 crisis. Therefore, we included a self-constructed scale to measure individuals' COVID-19 related stress and how this may influence respondents' intention to use a CTA. We also checked potential differences based on respondents' gender, age, education level, and self-reported health conditions. More information about the study can be found in the papers that are published open access and that you can find online. So a survey was administered in Belgium to 1,500 respondents aged 18 to 64 years old in collaboration with a professional research agency. Let's have a look at some of the results. In total, our model predicted 39% of the variance in intention to use the CTA, the contact tracing app. The most important predictor of intention was performance expectancy. The higher respondents value the impact of CTA can have on being informed about one's risks of being infected or other potential impacts to help limit the spread of COVID-19, well, the higher their intention to use the app. This major factor was followed by facilitating conditions and social influence that were also positively related to intention. The more individuals think they have the needed resources or knowledge to use the app, the more they think that significant others would recommend them to use the app, the higher their intention. Effort expectancy was not significantly related to intention, and with regard to our supplementary variables, we found that innovativeness and app-related privacy concerns were significantly related to intention. The higher individuals are in general involved in acquiring new technologies, giving others advice about technological innovations, the more they are inclined also to download this app. However, we saw that the higher individuals' concerns about the protection of their privacy when using the app, the less they are intended to use the contact tracing app. COVID-19 related stress was not significantly related to intention, and also the other sociodemographic variables were not related to the model's constructs. What are now the conclusions we draw from this first study? So the most important predictor of app use intention is performance expectancy. So it's important that governments launching and promoting a contact tracing app report clearly using graphs and other visualizations on the individual, but also the societal impact of using digital contact tracing. To enhance the interest and the perceived performance of the app, supplementary functions could also be offered. In some countries, for example, other functionalities have been added, such as information about symptoms, how to directly contact a health professional for advice, or making an appointment to get tested. Some applications have also been added in the further development of the CTA in Belgium, such as making a test appointment, issuing a quarantine certificate, filling in a passenger location form. So the app becomes a central hub with COVID-19 related information and advice. But also the possibility to directly contact a contact tracing advisor or health professional could be important. So it's essential that individuals are supported and stimulated to get tested and to have the possibility to get advice of a health professional. One of the observations made also by the developers of the Belgian app is that not all users who get warned activate the code to warn other users they have been in close proximity with. Some 37% of Corona Alert users who receive a positive COVID-19 test result confirmed their status through the app, which automatically and anonymously warns close contacts who use the app. So this essential last step in the procedure, confirming their COVID-19 status, is for some users an important threshold. Therefore, initiatives to motivate users to warn other users need to be strengthened. One of the major limitations of the system, how it was introduced in Belgium, is the lack of broad communication campaigns. Clear explanations were given on the website and in the app, but only textual information, demos and testimonials, as have been developed in other countries to promote CTAs, could be further used. More attention could have been given also to the inclusion of influencers and stimulating innovators to promote the app in their online and offline social network. And finally, as you have seen in the results, app-related privacy concerns negatively influenced app uptake intentions. So it is therefore important to continue to stress the data minimizing approach that has been used to develop this app. Let me then
Michel,
briefly,
Michel,
yes,
yeah, you have like 4 or 5 minutes left, so
okay,
just
no problem.
thanks.
Yes, Let me then briefly browse through the results of the next study we have conducted among a sample of 1,850 respondents. So in that study, we focused on the reasons why respondents did not install, installed but not activated, or uninstalled the app. Also, respondents' attitudes towards potential new functionalities that have already been introduced in other countries are discussed as potential options. Let's have a look at the results. So you see that a third of the respondents in this second study were users of the national contact tracing app Corona Alert. Among the non-users, we discern three different groups: a large majority who did not install the app, 1 in 10 non-users who first decided to install it but never activated it, and 5% of the users eventually deleted the app from their smartphone. Some of the results concerning the reasons why they did not install the app or not activated it or uninstalled it. Well, you see a comparison of the most important reasons that the respondents gave us in the three columns. The main reasons for not installing the app is seeing little advantage to do so. So in other words, potential users need to be more informed or convinced of the individual and also the broader societal advantages of the digital contact tracing app. Privacy concerns are also important. Worries that the use of a CTA and potentially being confronted with a message that one has a risky contact would cause some people to stress to use the app. 1/5 of the non-users is worried about government's use of the data. Also worries about the possibility of locating users or have a general lack of trust in digital contact tracing. Almost 1 in 10 non-users cannot use the app because they don't have a smartphone or have an older incompatible model. And so you can also see the figures among the individuals who did not activate or who uninstalled the app in this slide. Final results I want to present is that we checked also potential significant differences that there were concerning the potential impact of contact tracing technology in, for instance, tackling the COVID-19 crisis or other aspects. And you see in this slide that users are in general more convinced of the potential of a CTA than non-users. Finally, the last results, we measured also potential functionalities, and we submitted a list of potential functionalities that we can group in two categories: information and advice, or control and access. And these are the last results I present to you from this second study. You see that a large majority of current users are in favor of the integration of more information, such as statistics, etc. Also, the possibility to directly make an appointment to get tested and also to be in direct contact with a health professional for personal advice. You see also other functionalities that are more supported by the current users than the non-users. Also in the control and access category, you see that a small majority is in favor of using the app to control, for example, the whereabouts of COVID-19 infected individuals. So what are the recommendations based on this second study? So we see that there is a lack of convincing information about the impact of the CTA. More information about the results of studies concerning CTA need to be made available to the broader public. We see also similar results in other international studies. So if you are interested in these findings, but also the discussion of the findings and also the managerial and governmental implications based on our research results, I'm pleased to invite you to look at our paper that you can find online. What are now the next steps in this research project? Well, we are conducting in-depth interviews to investigate the motives and experiences of users. We have also a specific study on CTA privacy and trust. And we have done a study on coping with CTA alerts. So how is the adaptive or maladaptive coping behavior of people who get alerted that they had a risky contact? If you're interested, I'm referring to our project website, where you can find the already published open access publications. We have also a summary report in English and a full report of our first study in Dutch. And please don't hesitate to contact me if you want more information. And I'm pleased also to respond to your questions concerning this study. Thank you for your attention.
Thank you, Michel, for bringing this rich study in such a short period. You showed the catch-22 of the GOVTRUST apps. It needs to be, people want to use it when it's effective, but to be effective, people need to use it, right? So that's a bit of a difficult situation. Let's move over to the second presentation by Professor Katleen Gabriels. Welcome, joining us from the University of Maastricht. You're working on the co-shaping of morality and computer technology. I'm reading on your website, which is broadly situated in the field of the ethics of technology, which of course is a very topical issue today. You have a presentation on health self-tracking, so I'm really looking forward to your findings on this field. The floor is yours.
Thank you so much. Can you see my slides?
Perfectly.
Okay, great. Well, hello from the Netherlands. I'm in Maastricht, so that's so easy. So today I want to concisely introduce a study that I conducted a couple of years ago with Tanja Moerenhout. She's a medical doctor and also a philosopher. She's currently at the University of Otago in New Zealand. But I'll start with a broader introduction. So this is the outline of my presentation. But first, I want to say something more about the relation between, on the one hand, health and evolutions, technological evolution. So, for instance, the Internet of Things and AI technologies. So, many of you might have health apps on their smartphone or even a wrist wearable such as a Fitbit. So these are self-tracking technologies in order to enhance self-care. Today there's a lot of focus on self-management, self-analytics, self-measurements, but it's important to emphasize that self-tracking is never just self-tracking. You can openly share these data, for instance, with platforms such as Strava, or you can share them with friends in order to keep track of one another performances. For instance, how many steps have you taken today? But it's you also always share the data with a company. And when we're talking about ethics, some of you might have read in the news a couple of weeks ago that more expensive bikes get stolen because of Strava apps, because potential thieves, they can follow or they can track you through the use of Strava. Broader AI technologies and another thing that I focus on in my research. I guess you're all familiar with these studies that you train algorithms, in this particular case with 130,000 pictures of skin lesions, and the results show that the algorithms are as good as trained dermatologists in predicting skin cancer. However, we have to be very careful because this one links nicely with the previous presentation. We always have to, of course, focus on evidence-based tools. And my colleague at Maastricht University, Wouter Wijnands, she's a statistician. So this refers to a number of AI tools that have been built to beat the coronavirus. She also has a number of academic publications on it, and in the end they tested about 200 models, and only 4 of them turn out to be potentially useful. So although it's really important to, of course, develop AI tools in order to beat, in this particular case, a global pandemic, we always have to be very careful in terms of to what extent does it really solve the problem or helps solving the problems. So this particular study that I will present shortly is also fully available online, so you can read the entire study. It is published in the Journal of Medical Internet Research, and later this year the conceptual follow-up study will be published in an edited book chapter. So we were really interested in to what extent do people who self-track also share these data with medical doctors? So therefore, we decided to conduct an interview study with Belgian general practitioners, so Belgian GPs, and also Belgian cardiologists. Because when you're working as a medical doctor, self-tracking in itself is not new. For instance, when you have to treat a patient with diabetes, you often prescribe a glucose meter or a blood pressure meter. And even at home, we have bathroom scales. So that's also a form of self-tracking. And of course, we also have to be very critical at looking at to what extent does it help, for instance, with the bathroom scales, to what extent does it really help beating obesity? Because clearly, even though when we know what our weight is, it didn't really help the increase of obesity worldwide, because that's also a structural problem and not just an individual problem. But we were first and foremost really interested in the well, to what extent doctors were being confronted with digital self-tracking in their daily practice, because classic self-tracking is already a well-established form of daily medical practice. What are the differences? So when we're talking about classic self-tracking, think for instance of the glucose meter. Well, there it's the doctor who generally takes the incentive to self-track. So this is a form of pushed self-tracking. And then we have digital self-tracking. Very often it's the person, not even, it doesn't even have to be a patient, because many healthy 30-something sportive people track themselves. So this is a different form of who takes the initiative. And in contrast to classic self-tracking, it's really easy to share your data. And there's also a lot of literature on the question to what extent can all these digital data eventually become part of electronic health records, and which data is relevant for an electronic health record. Fortunately, the distinction between classic and digital self-tracking is not clear-cut, which helped us to compare both. So we had an in-depth interview with GPs and cardiologists, more on that in the open access publication. And this was our interview guide. So first we asked questions concerning classic self-tracking, something that all doctors were very familiar with. And then we asked the same set of questions about digital self-tracking. And this is what I will focus on in this presentation. I must say that at the time of the study 4 years ago, most of the medical doctors did not really encounter a lot of digital self-tracking in the daily practice. Cardiologists sometimes encountered it, but it was not yet a standard part of their daily practice. I also must emphasize that we did not just pick our sample at random. For instance, the cardiologists we interviewed, they were also involved in academic research on, for instance, apps related to cardiological medical problems. So they were also experts in this particular topic. I also must say that our sample had a very nuanced view, especially, for instance, on the benefits and pitfalls of digital self-tracking. In our body of data, 4 major themes arose, and I will quickly go over all the themes. Trust is particularly important with information management. I can already tell you that, for instance, with the classic forms of self-tracking, in Flanders, Domus Medica provides a list with reliable brands. But one of the major problems with digital self-tracking is that the clinical and the commercial market are entirely interwoven. So you don't really know which technologies are qualitative, which ones are reliable and which ones are not. As you might know as well, and we also mentioned this in the article, in Belgium they are working on a reimbursement framework for instance, health apps. I don't think that at this moment these apps have passed all the different stages. Some of them are quite close, but not haven't passed all of them. So the idea behind it is that, for instance, when you're suffering from insomnia, that your doctor doesn't prescribe you pills, but a sleeping app in order to gain more insight into your problems, because well, in the longer term, that might be more beneficial than taking medication. So these are the 4 major themes. The first one is really interesting and is also the focus of our conceptual follow-up study. And that's also related to a broader societal, well, you could say, hype, but that might not be the best word. Trends might be better. So when you're going to look, for instance, at our former federal minister of health, Magie de Blok, she called patients, or actually she called us all pilots in the cockpit, co-pilots in the cockpit of our health. So we are also responsible for managing our bodies. When Tim Cook was asked what Apple's most important contribution was to the world, he answered, well, it's managing offering everyone the possibility to manage one's health. So there's a lot of focus on this idea that we can all manage our health, and thanks to apps and self-trackers, we are given more opportunities. And the medical doctors in our study, they also saw the benefits of it. Because, for instance, when we're talking about glucose meters, so a classic form of self-tracking, it really helps people to gain understanding of their medical condition. condition. And also self-diagnosis is not new. So this is something that is also very much present with digital self-tracking, but also, for instance, patients who suffer from diabetes, based on the results, they sometimes also alter their own medication, but always within certain limits. So in a way, it's possible. It's a good thing that patients gain more insight into their own data. On the other hand, it was very clear that medical doctors would not just offer digital self-tracking to just anyone. For instance, someone who is already suffering from hypochondria, to what extent do you really help this person by giving more insight into the data? On the one hand, it might decrease the fears. On the other hand, it might even increase them. And this also links to a couple of very interesting trends, if I may say so. A couple of academic studies have already been published about sleeping apps, that some people get so worried by attaining the perfect sleep that these apps actually increase sleeping problems. Same with focusing too much on what you eat, for instance, that it becomes an obsession. An important sub-theme with a patient as health manager is the fact that even when you know that you have a problem, that very often people don't really change their behavior accordingly, for instance, when you're overweight, and the high dropout rate with active self-tracking. So, for instance, even in pilot studies where pregnant women were asked to measure their bodily weight and their blood pressure every day, the majority didn't succeed in and during the entire study, even though it would be beneficial for their baby. Then health obsession. So this is what the cardiologists were most frustrated about, is that sometimes they have healthy people making an appointment because they're worried. But very often it's because of the use of bad technology. And this is where the title of the article also comes from, because one of the cardiologists called this entertainment medicine. And this is a really critical question, because where do you draw the line between medical necessary data from digital self-tracking and what he called web data? On the other hand, our sample acknowledged that you always need a group of early adopters to basically open the path for other people, but most doctors were worried that in first instance already healthy people would use these technologies, which would even increase problems related to digital inclusion. And then information management, I think that's the most interesting one in relation to trust. So as I've already said, there's no list available for reliable data. Also, and this is related to the curriculum of our future doctors, at this moment we don't really prepare them for a job that will have so many data. Also for GPs, for instance, the older GPs said, well, I didn't study to sit behind my computer, and how can I interpret all these data? What is really important is the importance of context. So I would like to share a quote. So this was from a cardiologist who also was involved in research, in particular about a heart rhythm app on your smartphone. This was part of the research, and at a Saturday evening, quite late, he received an email with a deviated heart rate measurement, and apparently there was nothing wrong. So the person using the app was at a reception, and he saw someone who said that he suffered from heart rhythm disorder, and he subsequently gave him a smartphone to try the technology. So all these data are collected by the same technology, and self-tracking often strips away context, which is really important, which is really dangerous when therapeutic decisions are made based on distorted data. So how will you guarantee that this is not the case, that, for instance, a device is not being shared by different people? In contrast to active self-tracking, there's also passive self-tracking, for instance, pacemakers, and these patients are also followed by telemonitoring, which is well, it's completely different, but in a way there are some relations. Of course, you don't have a dropout rate there, and this problem of context does not arise. And then finally, the shifting role of the doctor. I guess most of you have already heard of this transition to a new role of the doctor, that the doctor, because of all these apps and trackers, becomes more of a coach. And then the question of responsibility arises, because on the one hand, for instance, the GPs like the fact that having all these data is more reliable than just one measure while visiting the doctor, but at the same time, they're really worried about the threshold. So from what moment onward should you be alarmed, and what if you don't notice an alarm? And so this is really part of a bigger discussion, what I've already mentioned, which data are relevant to share in a medical file, which are not. Also, and this also relates to a broader criticism, sometimes people think that, well, if we just collect all the data, the pattern will arise by itself. But of course, this is not true. The problem will often become even more complex. And then I have some final minutes, I see. So I just want to say something very quickly about the follow-up study. I can share the link in the chat later, but it's not published yet, because we were really interested in this whole idea of the patient manager, because the patient on the one hand has a passive meaning, where on the other hand a manager is really active, knowing what the goals are. And our ultimate criticism or fear is that, for instance, policymakers use this patient manager discourse in order to reduce costs that go together with the challenges of aging populations. So they sell patient managers, or this entire discourse, as autonomy and empowerment. And then I will close my presentation, but we are actually very much afraid that this will lead to a new dependency, namely a technological dependency, because you will become so much dependent on all the different nudges and norms of technology. And that might even lead to a new form of paternalism, namely technological paternalism, where the technology is basically telling you what to do. And this is not something that I make up, because, for instance, in the Netherlands, you have Kepler Vision, and that's smart video monitoring, making use of AI technologies. And basically, it constantly films elderly people still living at home, and it also takes into consideration their medical records. For instance, are they drinking enough? So they're being filmed and analyzed the entire day. So to what extent does this really protect their autonomy? So these are questions that we discuss in the follow-up article. Thank you.
Thank you. Thank you for the presentation, a very rich and interesting presentation on health apps and health technologies. Well, we're already at the time of the break, so an extended question round will not be possible. I'm afraid if there's somebody with a burning question, though, which please do so. So. Who wants to ask a question? I saw that one question in the chat was for Michel to ask, did you also hear altruistic arguments for using the app?
Yes, thank you, Wouter. I just replied in the chat to the question of Charles. So I didn't add all the reasons we have investigated in our study on the slide. So in the paper you will find other reasons and also societal, more altruistic reasons. You help the government in its fight against the pandemic. You help also protect your relatives, for example, when you have that app and can rapidly detect if you have had a risky contact.
Yes, thank you. Thank you, Katleen, for posting the link to the article in the chat as well. It's very useful. Maybe one small question on the presentation of Katleen. So you warn for a lot of things, and also in the last slide you give a warning about what could potentially go wrong. I'm in public administration, so I'm always interested to hear what the government should do. Are there any guidelines for policy? If maybe not, maybe it's in our hands, but can you maybe quickly give some thoughts on that?
Well, yeah, with the apps, there are clear policies. So all these apps have to go through very severe screening before they could be reimbursed. I think one of the big problems with, for instance, the smart video monitoring that I was referring to in my final slides, and which is also at the core of the article that I just posted, is the public-private collaboration. And this is not new. For instance, in the UK, Google was already involved with the National Health Service, but this is something to be, well, again, very critical about, because on the one hand, we will know that these companies, for instance, Google, have the best technologies. For instance, Google also acquired Fitbit some years ago. But at the other hand, we need very clear policy regulations there, which data are shared, and what is one of the most important arguments of our follow-up article is that you should really educate people about this, and this eventually might not even reduce costs, because informing people and their caregivers in depth about how all these technologies work is actually a big investment of time and costs and energy, and this is something that policymakers don't always focus on.
Yes, and maybe follow up also on the first presentation where transparency was a key word, but on the other hand, for private companies, the lack of transparency is their business model, right? So are you up to the task as an individual citizens to even if you understand, to know what's going on?
Well, at least if you want to know, it should be very clear, and the information should be available. But it even goes further from an ethical perspective. So currently, we're also following a lot of norms that aren't even evidence-based. So, for instance, the 10,000 steps per day, it's not based on clinical research, and still we're all abiding by that norm. But if you're going to look at, for instance, digital self-tracking technologies, they also often give a number of goals. Or you also have like internet-connected pill boxes, and if the patient doesn't take their medication, the pill box will make sound and will have different colors, and will eventually call the patient to remind him or her to take their medication. And of course, you can focus on the good side of this, but on the other hand, you could also focus on the rather paternalistic aspect of this, especially if these data are also shared with, for instance, children and other caregivers. So I'm very sorry that ethicists always focus on more problems, but it's a very complex problem, and there's many aspects that we have to take into consideration.
Yes, thank you. Thank you also for reminding me about the 10,000 steps, which is an aspirational goal for me. No, thank you for the presentations. I think we can go to the break now and reconvene at 4 o'clock. So that gives you some time at least to get a coffee or something else to drink. And we'll reconvene again here in the same room at 4 o'clock. Thank you.